I appreciate the opportunity to be with you today. I was asked by the Continuing and Medical Education Department to do a continuing education program on multimodal pain management. My name is Dr. Craig Ryan. I'm the Regional Chief Medical Officer at Covenant Health in Lubbock. And I want to start out this entire presentation by stating clearly and for the record that I am not a pain management specialist. I'm a surgeon, trauma surgeon by training, and I've been a Regional Chief Medical Officer up at Covenant in Lubbock for the last 7.5 years. So you might wonder, what in the world is a Regional Chief Medical Officer doing talking about pain management? As I stated, I'm not a pain management expert, but I treated pain for my entire career. And I will be honest with you and tell you that I probably did it very poorly. We know that there are new modalities in pain management that help us do a much better job with pain management than we've ever done before. And when people say, well, wouldn't it be better coming from a pain management expert, an anesthesiologist that specializes in pain management? My answer to that is we are all, as physicians, in charge of managing pain. That's what we do. That's what we were trained to do. You don't need a pain management fellowship to know how to manage pain and manage it effectively. And unlike old dogs, we can learn new tricks. One of the things that I wanted to just share with you is this is a picture of my home. This is Covenant Medical Center and Covenant Women's and Children's Hospital. And as you can tell by the picture, there are multiple standing bodies of water in Lubbock, all of which is absolutely fiction. Lubbock is just as dry as Abilene is, and I'm not sure who put this together, but this shows a picture of the buildings and a fictitious lake. We are part of the Providence St. Joe Health System. We started out life being part of the St. Joseph Health System based in California and Texas. We have now joined the Providence system in the Pacific Northwest. So these are all of the states that we actually have hospitals and administrative functions over. And we are a very, very large not-for-profit healthcare system across the entire Western United States. We know that the paradigms for patient care have changed. Over the past several years, we've become more and more responsible for quality, safety, and the experience of our patients' care. And part of that patient care experience is the consumer assessment of healthcare providers. Now, that is in transition. A couple of years ago, when I first started doing this talk, there was an emphasis in HCAHPS on pain management. And the problem with that is that the focus on pain management was thought to possibly be driving some of us to overprescribe opioid monotherapy, and that resulted in potentially increased adverse events. You've read about it in the news, you've heard about it on TV. There's an opioid crisis in this country, not necessarily of the physician's fault, but there have been some unscrupulous physicians that have taken advantage of the population for a profit motive to prescribe unnecessary and unusual amounts of pain management. One of the things that we can learn from that entire opioid crisis is there may be a better way for us to do it. One of the physicians in my place said that asking my patients about my treatment plan is a little bit like asking my teenagers how they like my parenting skills. I really like that quote. And it's true. Our patients don't really understand the nuance of what we do as physicians. They don't understand some of the judgment calls we have to make. They don't understand that sometimes what they may be asking for is not in their best interest. So it's incumbent upon us as physicians to take the time to explain to our patients why we do what we do, why we can't give them massive amounts of narcotics when they're in pain, and why there may be a better way to respond to their pain needs. These are the questions that were on the original HCAHPS surveys, and they said, during this hospital stay, did you need medication for pain? If the answer is no, it skips on to the other questions. If the answer, however, is yes, they ask the patient during this hospital stay, how often was your pain well controlled? And the only answer that really counts for us is always. If they answer anything else, usually, sometimes, never, it doesn't count toward our HCAHPS top box scores. During the hospital stay, how often did the hospital staff do everything they could to help you with your pain? Again, the same range of never through always. And again, the only thing that really counts toward our success is if the patients answer always. So traditional pain management, and this is what I grew up with, this is what many of you probably grew up with. If a patient had mild pain, we gave them a fairly mild opioid. If they had moderate pain, we gave them a stronger opioid or more of the same. And if they had severe pain, we gave them a whole lot of opioid. And that brought with it all kinds of complications, such as the opioid side effects, overdoses, respiratory depression, mental depression, confusion, etc. All of those things can be ascribed to traditional pain management. The traditional thinking that we all had, and I grew up with this as well as you did, is that single pain management regimens were easier to titrate. There was less risk of a drug-drug interaction if we were only using a single medication. If I give more than one medication, I won't be able to determine which one may be causing a problem if a problem arises, and it will be simpler to transition a patient home if I only give a single pain medication. I'll save money, I'll avoid risk, and will only give pain medications when they're absolutely needed. The problem with the traditional thinking is it's all wrong. We've learned that there are better ways to do this, and the traditional ways of thinking about pain management have led us down a path that's really not a good way for us to be managing our patients' pain. So what are the problems with that traditional thinking? We know that approximately 46 million people have inpatient procedures, and 35 million more have outpatient surgeries performed in the U.S. This was in 2006. And with the advent of the HCAHPS survey, we began to really ask whether or not we were adequately controlling their pain. And despite the new treatment standards, guidelines, the education that we did, acute postoperative pain continues to be undertreated, and up to 75% of our patients in the United States still failed to receive adequate postoperative pain relief. 75%. That means 3 out of 4 of our patients never got adequate pain management in the inpatient or outpatient post-surgical arena. That's pretty amazing that we were doing that poor a job of managing our patients' pain. Part of the problem is with the traditional approach is that the more we push a single mode of analgesia, the greater the degree of side effects, the respiratory depression, the confusion, the delirium, all of those kinds of things get worse the more often and more opioid medication we give them, which was our traditional approach. So how do we change it? How do we make a difference? How do we get the patient's pain under control without producing all of those side effects and producing some of the narcotic dependency that is so hot in the press and in the literature right now? We got to understand pain targets. One way I like to think about this is like the New York subway. I lived in New York when I did my fellowship for 2 years, and I learned fairly quickly that if you wanted to go from the top of Manhattan to the bottom of Manhattan quickly, you got on the express train, the express subway, the one that only stopped every 3 or 4 stations, not at every station. If you wanted to take all day to go from the south to the north or north to south in Manhattan, you took the local because it stopped at every single station. So one of the things that I would like you to think about is in the management of pain, make the pain take the local. Make it stop at every single station, make it fight its way through those stations, and it reduces itself in intensity as it has to make those transitions. Now I'm going to show you what I'm talking about. We know that pain originates generally in the skin. There are a million different types of nerve endings. It's really the free nerve ending that's most responsible for the pain transmission in most instances. Some of them are sensitized to heat, some cold. They do all kinds of different things, pressure, but the free nerve endings are the ones that really are moderating pain in the local environment where the injury or incision occurs. We know that we have nociceptors, they have different types of signal molecules, and those all go into local neurons that get targeted up toward the spinal cord. We know that pain messaging can be very confusing. The traditional teaching in general surgery was that acute appendicitis generally starts as a nonspecific generalized abdominal pain that only toward the last few hours of its clinical manifestation does it start to radiate to and localize in the right lower quadrant. And that's because our bodies don't have a good appreciation of where visceral pain or intestinal pain is. It knows that there's something wrong. We get nausea, we get anorexia, but we don't really localize pain in our GI tracts real well. Until the inflammation of the appendix actually reaches the abdominal wall and we start to inflame the somatic nerves in the abdominal wall, then and only then do our brains start to localize and recognize where that pain is located in the right lower quadrant. And that's the result of the fact that our bodies are wired differently in different areas. The pain of skin and abdominal wall, feet, fingers, face, all of those are much more readily attuned to pain stimuli than we have in our intestines. So it's only when the inflammation involves the abdominal wall that we really start to see the localization and identification of exactly where the pain source is located. So we can have confusing pain messages, and it's not as simple as it seems. Once the pain gets started, for instance, in this case, this is an injury to the thumb, and once the pain gets transmitted up the axons from the free nerve endings in the thumb all the way to the spinal cord, there is a synaptic switching point in the dorsal root column. And at that synaptic switching point, we are afforded an incredibly great opportunity to interfere with that pain signal before it goes on to the ascending pathways up to the brain. If you look at that interruption of pain transmission, when we have a synapse, a break in the neural network, there is actually a transmission of neurotransmitters across that synapse, and we can either block the release of inflammatory mediators, we can block the uptake of inflammatory mediators on the opposite side of the synapse before that ever gets up to the spinal cord. So that's what I mean when I'm saying make pain take the local. Make it stop, make it have difficulty getting through that synapse, and we can use that synapse to moderate pain. The interruption of the pain transmission is exactly as I said. There's that synaptic gap. We can either block the stimulus before it ever gets to the synapse. We can block the release of those neuroendocrine mediators. We can block the uptake of those neuroendocrine mediators before they go on to the brain. So that gives us a wonderful opportunity to mediate pain outside of the true central nervous system. Once those pain fibers get across that synapse, once the neurotransmitters get transmitted and the ascending pathways recognize that pain is on its way north to the brain, we have another opportunity up in the brain itself to actually interfere with the pain response. So those are the stations that we're talking about. We can interrupt the pain locally at the source and the skin or the part of the body that's affected. We can interfere with the pain transmission at the dorsal root column, and we can interfere with pain perception up in the central nervous system in the brain itself. So those are the sites that we can target to use multimodal pain therapy. And rather than just throwing massive numbers of narcotics at pain, we can use those sites very selectively to help moderate our pain response. If you look at the different pain components, there are a number of them that we need to appreciate. Pain is not all identical. I learned early on in my career that when I was asking my patients about pain, I wanted to know what the onset, what the location was, what the duration was, where it was radiating to. What was the quality of the pain? Was there anything that would precipitate it, anything that would relieve it, and any other associated findings? These are some of the things that can help us identify what the pain source is, and they help us in identifying the pain source, and they help also to moderate what type of pain response that we want to give the patient. So all of these are important questions to ask, and they're often forgotten or neglected. So always ask your patient those components of their pain. This is probably the most important slide I'm going to show you. This is how pain gets formulated and transmitted in our bodies predominantly. We biosynthesize prostaglandins by the cyclooxygenase enzymes from arachidonic acid precursors. That gives us an incredible chance to stop the actual production of the pain response by blocking the creation of the prostaglandins that mediate the pain. This is probably the most important slide I'm going to show. And the one thing that I want everybody to remember from this slide is not the biochemical pathways, it's not the conversions, it's not the end products. It's the fact that once these chemical mediators are actually generated, they will have pain caused by these mediators until the mediators are actually metabolized or excreted from the system, and that occurs about 6 hours after they're formed. So blocking the creation of these mediators is fundamental. Chasing them after they're formed is essentially too late. So I always likened PRN pain medication to the pain roller coaster. It's very simple. When a patient has pain in the postoperative period, what we've traditionally done is sock them with a lot of narcotics. We've gotten their pain under control. We've told the nurses if the pain comes back, give them more in 6 hours or 8 hours. And what happens is they'll get their pain under control, and then it will slowly come back for 6 hours. And if we allow time to pass and those inflammatory mediators to form, we're going to have pain. We can treat it again on an as-needed basis, and that pain will be there for 6 hours until those mediators are metabolized. So it is a roller coaster. If that's all we're going to do and treat pain on a PRN basis, we'll never get ahead of the curve. We'll always be in that cycle of pain, over-sedation, pain, over-sedation. So treating pain consistently and maintaining a level of pain control is a much better way to approach pain management. The opportunities by doing multimodal approaches, in other words, using multiple drugs rather than a single drug, we can use lower doses of every single drug. Well, the effect of that is that it minimizes the side effects of those drugs. So it's a little more complicated. It takes a little more attention to detail. But by using multimodal analgesic approach, we can manage our patient's pain much better than if we were using large doses of a single agent. So multimodal therapy looks like this. You'll remember the first triangle we showed, and it showed small amounts of opioids, larger amounts of opioids, and severe pain was treated with exceedingly large doses of opioids. The new multimodal therapy approach is very different. It involves the use of acetaminophen, the non-steroidal anti-inflammatories, the cyclooxygenase inhibitors, and local or regional anesthetics. In other words, we're treating pain by blocking the transmission in the initial free nerve ending. We're blocking the formation of the pain-mediating cyclooxygenase produced prostaglandins, and we can do that without any narcotics at all. That's the first step. Acetaminophen, non-steroidals, cyclooxygenase inhibitors, local and regional anesthesia, with no narcotics at all to start with. Only if the patient still has pain after we've exhausted those capabilities should we add low doses of opioids. And of course, for major things like thoracotomies and major abdominal surgery, higher doses of opioids are appropriate. The multimodal paradigm for pain management states that if we use 2 or more analgesic agents, these will act by different mechanisms, and they can provide superior analgesic efficacy without all of the complications and side effects that we've traditionally had to fight. Again, multimodal pain therapy shows where all of these agents work. At the local site of tissue inflammation, we can use local anesthetics. Non-steroidal anti-inflammatories and cyclooxygenase inhibitors can block the pain transmission before it ever reaches the spinal cord. Once it does reach the spinal cord, we can furthermore moderate it by making it difficult. Opioids do work there in the spinal cord to some degree, but we can use the alpha-2 antagonists like clonidine and NMDA antagonists like ketamine to block the transmission across that spinal cord synapse. Once the pain signal reaches the brain, all of the following, the opioids, the alpha-2 antagonists, the acetaminophen, and NMDA antagonists, all work to help moderate the sensation of pain in the central nervous system. The Joint Commission has actually released a Sentinel event alert, and what they have said is that for the use of opioids in hospital, it needs to be safe. And their recommendation is that we use non-pharmacologic therapies, physical therapy, acupuncture, manipulation, massage, ice. There's all kinds of non-medication related things that we can do to moderate a patient's pain. The pharmacologic treatment should start with a non-opioid analgesic, such as acetaminophen, the non-steroidals, the antidepressants, the anticonvulsants, as we've talked about. Even the muscle relaxants can be used before we ever start down the opioid trail. Once we use those things, they can be used in combination with opioids, but these non-opioid pharmacologic treatments may reduce the dose of opioids that are required to help manage our patient's pain effectively. The American Society of Anesthesiologists has likewise weighed in on this, and what they have suggested is that unless contraindicated, the patient should receive an around-the-clock, not PRN, an around-the-clock regimen of a non-opioid agent. And only if the patient continues to have pain breakthrough should we add low doses of safe levels of narcotics. We can also consider supplemental regional anesthetic techniques, and our anesthesiologists are absolute pros at making those kinds of things happen. So here are the non-opioids that we can use to perform multimodal pain treatment plans. We've already talked about the IV and the PO acetaminophen. There are some differences there, primarily in cost. The IV acetaminophen should probably only be used in those patients with absolutely no functioning GI tract. You do get slightly higher levels in the brain with IV than you do with PO. But if a patient has a functioning GI tract, the cost probably doesn't justify the administration of the IV acetaminophen, and it should be reserved for those patients that simply have no functioning GI tract. The alpha-2 antagonists, such as clonidine and dexmedetomidine, also work again to block that pain transmission toward the central nervous system. The gabapentinoids, gabapentin and pregabalin, work very well. Local anesthetics such as bupivacaine, lidocaine, and even liposomal bupivacaine, which we'll talk about a little more in just a moment. The ketamine, which is the NMDA receptor antagonist, which is growing rapidly in its utilization for inpatient pain management. And of course, the non-steroidal anti-inflammatories like celecoxib, ibuprofen, and ketorolac are all excellent in the use and non-narcotic use of pain medication regimens. So preemptive analgesia, we can do local anesthesia, we can do regional anesthesia, we can add non-steroidals, and of course in the operating room particularly, IV acetaminophen may be appropriate in certain select instances. The opioid-sparing medications like gabapentinoids, the pregabalin or gabapentin, there's a little bit of difference in the onset. and I'll show you a proposed regimen that makes it most cost effective to switch from one to the other here in just a few moments. The central prostaglandin inhibitors, like the IV acetaminophen, are for mild to moderate pain while patients are NPO. Once the patient is able to take oral medications, it doesn't make a lot of sense to continue IV acetaminophen in those patients. And if they're tolerating a regular diet, they probably should be switched as quickly as possible. These are the opioid-sparing medications. Other opioid-sparing medications are the non-steroidal anti-inhibitors, non-steroidal anti-inflammatory inhibitors, and the COX inhibitors. And a lot of our anesthesiologists like to give ketorolac load and then follow that up with celecoxib, because that combination is very potent in moderating the cyclooxygenase inhibitors and preventing the formation of those inflammatory mediators that we've already discussed. That helps us keep our patients off of that pain roller coaster. We can use an opioid such as a very weak mu opioid or serotonin reuptake inhibitor such as tramadol. It comes in various forms and in various strengths. Some people that advocate multimodal pain therapy are big advocates of the use of tramadol. Some are less enthusiastic about using it, but it is a very weak mu opioid, meaning that it's not as likely to interfere with GI motility as some of the more potent opioids are. The other ones are methadone, which can be given as a basal around-the-clock regimen of 5 milligrams every 8 hours, or oxycodone as needed. And this is usually a combination used to treat moderate pain. Now, they come in multiple forms. Oxycodone has been one of those medications that's under a lot of controversy right now because of its potential for abuse and the fact that it seems to be one of the drugs of choice for people that have developed a narcotic addiction. One of the things that we don't have a lot of experience with is methadone. All of us grew up in an era where methadone was typically used to treat narcotic addiction. And it got a reputation as being a medication that was exclusively used for potentially heroin addiction. We've largely ignored it. But in essence, there is a lot and a growing body of literature that suggests that methadone itself is an incredibly powerful pain medication, and it doesn't have some of the side effects that some of the other opioids do. So there's actually a study from Japan. It was in the Japanese Society of Anesthesiologists in 2014, and they compared morphine versus methadone, PCAs, over 24 hours, and fascinatingly, the methadone had less opioid consumption in a PCA than the morphine did, and the patients that were on methadone had lower pain scores, both at rest and in motion, than the patients that were treated with morphine. And if you're like me, you were taught in medical school that morphine was the gold standard, morphine was the best narcotic out there for treatment of pain medication. But in fact, there's starting to be a growing body of evidence that we can use methadone on an around-the-clock basis at low doses and really help moderate our patients' pain better than we can with some of the traditional narcotics such as morphine. There are no controlled studies right now that I'm aware of that compare methadone orally with oxycodone, so that's a question that remains to be answered. For severe pain, some of the multimodal pain management specialists around the country are advocating methadone basal of PO 10 milligrams every 8 hours. And again, that's not PRN, that's every 8 hours scheduled so that we can stay ahead of the pain. The oxycodone can be added on an as-needed basis. And this is only really to be treated at the very top of that pyramid where we're seeing severe pain with a pain scale of 7 to 10. The refractory severe pain can be treated with IV treatments such as methadone, hydromorphone, even IV fentanyl very carefully. a ketamine drip or even a lidocaine drip can be effective in treating refractory pain that's not affected by the other multimodal managements. If you look at EXPAREL, liposomal bupivacaine came on the market just a few years ago, and it's gotten a lot of press. It's also incredibly expensive at this point in time. Now, I'm hoping that the price of it will come down. It is a good pain medication, but it's not the panacea that a lot of surgeons think it may be. It's been very effective in knee replacements, and most of the studies on it have been in orthopedics. And many healthcare systems, because of the cost of liposomal bupivacaine, have also considered removing liposomal bupivacaine from their formulary due to the excessive cost. It's very expensive. It costs right now at Covenant, it's costing us about $320 to $340 a vial. There is no generic that I'm aware of. And it is a significant cost to the organization, and we're struggling with the cost to benefit ratio. If you look at the way EXPAREL is used, it cannot be used the same way that you use plain bupivacaine. Bupivacaine is an aqueous solution. We inject it, it infiltrates the tissue, it soaks in just like lidocaine does, and it spreads out over the tissues. The EXPAREL is a suspension. It's a liposomal form. It stays where it's injected. So you have to be precise where you inject it. It does no good if you don't get it in precisely the right spot. It requires many more injections than other local anesthetics to receive adequate coverage. And these are the reasons why I'm arguing that it may not be the panacea that a lot of folks thought it might be originally because of its long half-life. It's not going to have an effect with its long half-life if we don't get it in the right spot, because again, it does not diffuse through the tissues the way bupivacaine aqueous does. The one thing I will say in its defense is it is absolutely wonderful for our elderly patients that have rib fractures. We know that about 30% of our patients, traumatized elderly patients that get rib fractures, will not breathe deeply, they will splint, they will get pneumonias, and not only will we be treating their traumatic injuries, we'll be treating the effects of those, such as the pneumonias that are acquired from not breathing deep because of the excessive pain from rib fractures. So techniques such as intercostal nerve blocks and bupivacaine, liposomal, is absolutely a wonderful way to do that. It is invasive, but it's more effective than systemic opioids, produces less systemic side effects. And to my way of thinking as a trauma surgeon by training, rib blocks with liposomal bupivacaine have really been instrumental in reducing the number of injections that we have to give our patients and reducing the number of patients that actually come down with pneumonias that we have to treat later on, increasing the cost of their care and their length of stay. If you look at the way orthopedics has used multimodal pain management, here are a couple of things that came out of the Journal of Bone and Joint Surgery in 2011, and they were recommending for total hips and total knees an almost identical regimen of acetaminophen, celecoxib, and pregabalin in the preoperative period. They were using different forms of anesthetic, both spinal or a combination femoral nerve block or general anesthesia with femoral nerve block in the knees, or just simply general anesthesia in general for total hip replacements. For the postoperative period, they were recommending acetaminophen, celecoxib, pregabalin, and the IV or PCA or PO opioids for a total hip. For a total knee, they were recommending epidurals, femoral nerve blocks, and the regimen that you see there of acetaminophen, celecoxib, pregabalin, or an IV PCA if all of those things are ineffective in managing the patient's pain. So you see how the combinations work here, and this has really been very effective in reducing the pain that we perceive after a total hip or a total knee. I got this from Dr. Ron Alvarado from the University of Texas Health Science Center in Houston. This was his example of polytrauma acute management. And this shows all of the choices that you can make. Now, neither he nor I would ever use all of these medications on every single patient, but it shows you how you can change over the course of hospital days 1 through 6 the types of medications that are appropriate. He starts with a single dose of IV ketorolac. He does the COX inhibitors, the Celebrex for the first 2 days, and then switches them to naproxen for the days 3 through 6. He uses IV acetaminophen on trauma patients for the first 48 hours until we know that their GI tract is functioning and non-injured, and then switches them to the PO acetaminophen every 6 hours on a scheduled basis, not on a PRN basis. He uses Lyrica for the first 100 milligrams for the first 2 days every 8 hours, and then switches them to Neurontin, which is a little bit less expensive and has a little bit slower uptake, but does a great job over the long course of their pain management. He uses Ultram throughout, and the opioids he tries methadone first, and then he is able to, usually within 72 hours, switch them to a Norco combination by reducing the acetaminophen above and switching them to Norco after that for the remainder of their stay. So this is just an example of the choices that can be made for multimodal pain management. I took the liberty of using his data, and I went to our pharmacology department and looked at the cost of all of this. I mean, it looks like it would cost an arm and a leg to do all of this. But if you really look at the wholesale acquisition cost to the hospital, and these are estimates, these are wholesale acquisition costs that are national numbers. These are not contract numbers because we have non-disclosure agreements with our pharmaceutical companies not to disclose the actual contracted numbers that we have on our books. But if you look at the cost, the IV Toradol is costing us about $3.75. The Celebrex, $10. Naproxen, 20 cents. The IV acetaminophen is fairly expensive on the national market, but the PO acetaminophen, you can see the dramatic drop in cost on that. Lyrica is a little more expensive. The wholesale acquisition cost when this slide was produced was $7.50. And that's a single dose cost, and the Neurontin was only about 40 cents, which is one of the reasons that we want to switch after the first 48 hours. Methadone is incredibly cost favorable. It's only 31 cents a dose, and the Norco is about 38 cents a dose. Now, no one would give every single patient all of these pain medications. But let's assume for the moment that you did. If you gave your patients every single one of these pain medications, the total hospital cost would be $393. That's amazingly cheap in this day and age. Now, if you add liposomal bupivacaine, you're going to double that almost instantly. So, just to show you that multimodal pain management does not have to be expensive. It really doesn't. In fact, that's a relatively low amount for a very, very busy regimen of pain medications. The demonstrated benefits of multimodal therapy, it reduces the opioids in the treatment plan, which everybody is very focused on these days. It reduces those opioid side effects. We actually get better pain relief than is possible with any single analgesic, and it's secondary to the synergistic and additive effects of these multimodal pain regimens. We have fewer gaps. In other words, our patient don't wake up in the middle of the night screaming in pain, and then it doesn't take 6 hours to get their pain back under control again. They have less pain during rest and activity. They do have improved functional outcomes. They get up, they get out of bed, they get moving, their respiratory status is better. We get less postoperative atelectasis, less pneumonia. And very importantly in this day and age, our patient satisfaction goes up. We have now managed their pain much better, and they have a much greater appreciation for what we've done for them than if we're trying to chase our tails with PRN pain medication. So again, this is complex, it's multifactorial, but it's a balanced therapeutic approach. The call to action. How do we do this? How do we implement this? We know that the Joint Commission has released their positions on this. They've got Safe Opioid Administration Sentinel event alerts. They've recommended multimodal as a standard. The Center for Medicare and Medicaid Services has recommended broad assessment and monitoring recommendations. We know that HCAHPS has a correlation with the use of multimodal pain, and the Institute for Safe Medical Practice has also weighed in and said this is the way to go in this day and age. If you look at the implementation of practice changes, it does absolutely no good to just educate the medical staff. If you don't educate the nursing staff what we're doing, how we're doing it, and why we're doing it, they will think we've lost our minds. I got a phone call from my nurses in ICU. We had a young resident on the surgical service, and he went by and decided he was going to implement a multimodal pain regimen for one of our patients in ICU, and he ordered clonidine for pain. And the nurses immediately lit up the switchboard, started calling my office saying, this guy's crazy, he doesn't know what he's doing, that's an antihypertensive medication. They've never seen it used for pain before, and they thought he needed to be taken to a rubber room in a straitjacket. The answer was he knew exactly what he was doing. Clonidine is a very good adjunctive medication for a multimodal pain regimen. So it takes education not only to the medical staff, it takes education to the nursing staff that this is a new way to manage our patients' pain more effectively. So you have to do both. You have to get your advanced practice nurses, your frontline nurses. Pharmacy has to be on board with it. Quality and patient safety should be involved with it from the start. Risk management should be very proud of these efforts because they do reduce the risk of monomodal pain management significantly. And the rapid response team should be aware that these practice changes are in progress. If you look at the implementation of practice change, and I don't say this very often, there's very little that I think most physicians believe that the electronic health record has improved healthcare with. The one thing that it does improve healthcare with is that it gives us an order set in the electronic health record that helps us provide that balance between safe, evidence-based prescriptive direction and practitioner autonomy. It is very difficult to just sit down with an order set and a pen and start writing this stuff out. It is much more effective and much safer to do multimodal pain management as part of an electronic medical order set. So there is the one huge advantage for the EMR right here, that multimodal pain management treatment is much easier and much safer with an EMR order set. The EMR modifications to support these practices need to be done, and we all need to agree on what they should say. Now, does it work? One of my sister institutions in the Pacific Northwest actually initiated their multimodal pain management order set, and they followed over time the utilization of that multimodal pain management order set, which is indicated by the blue line on this graph. They also looked at the overall use of opioids in their institution and to determine whether or not the number and the amount of opioids prescribed out of the pharmacy was actually dropping based on the use of those order sets. And as you can see, there is a tremendous correlation. You can't say that it's absolutely cause and effect, but it is highly likely that the institution of the multimodal order sets in the EMR was a direct result, or a direct cause, I should say, of the reduction in the overall amount of opioids that were leaving the pharmacy to the bedside. Looking at it a different way, the light blue bars in this group show that the preoperative multimodal pain management order set usage has increased over time. The postoperative multimodal pain management order set usage has also increased over time. And again, the red line there indicates the reduction in the overall opioid use in that particular institution. Now, these are preliminary results. They're unpublished at this time, but they are so strongly correlating, I thought it was worth sharing those with you today. Now, as I said when we started this, I am a chief medical officer, which means my clinical practice has been largely curtailed. I still operate, I still do occasional cases, but I've limited my practice to outpatient surgery because it's a whole lot easier to do that than it is to have a hospital full of patients that are expecting me to give them my undivided attention. So I've limited my practice to outpatient surgery. While doing that, I've done a few gallbladders, hernias, those kinds of things. I try to restrict my practice because it's not fair to my patients to not be able to devote the time. So I had a young lady walk in my office, and she, simple, straightforward, needed her gallbladder out. She had gallstones, no inflammation, no white count. So we set her up for laparoscopic cholecystectomy on an outpatient basis. When I was doing her medication reconciliation, it struck me that she was on large doses of hydrocodone. She was taking 7.5 milligrams of hydrocodone around the clock because of chronic low back pain. I absolutely shook my head because I wasn't sure how I was going to be able to effectively manage postoperative pain in a patient that was so habituated to narcotics from her primary care physician back home. So I took my own medicine. I gave her a preoperative dose of pregabalin. I gave her a dose of IV acetaminophen the minute she went to sleep. I gave her a dose of ketorolac in the operating room as soon as she was asleep. And we took her gallbladder out and patched her up and shipped her to a recovery room and back to outpatient surgery, expecting the worst. She was the 8 o'clock case that day. It just so happened that my anesthesiologist and I arrived at the bedside for her postoperative check at approximately 11 in the morning, and she looked absolutely wonderful. We looked at each other, we shrugged and said, well, if you look this good and you've met all our parameters, we think you can get up and go home. And this woman, who had had years of chronic back pain, stated that she had less pain that day postoperatively than she had had in years. And when we told her she could go home, she literally sprung out of bed like a kid on Christmas morning, ready to put her clothes on and hit the door. Now, beware the man with a series of one, but I'm just saying, it works. It really works. Our trauma surgeons have started utilizing these multimodal pain regimens, and they have seen a dramatic difference in our patients. They've seen much fewer complications. They've seen no respiratory depression, and it does change and get us back to the paradigm for acute patient care. And we can improve the quality, the safety, and the experience of care by using things like multimodal pain management with all that entails. So when your patients are in pain, make that pain take the local. Don't let it go on the express. Interrupt it at every possible opportunity. Use multimodal pain management. Use it on a regular basis, not a PRN basis, because you don't want them to ride that pain roller coaster. So thank you for your attention, and I appreciate you being willing to move into the future with us. Thank you.